Okay, great. So I am really, really excited to introduce our next speaker. When we came up with the idea for the conference, Dana Lewis was one of the two first people that we actually reached out to, and her story is amazing. And I'm not going to spend a lot of time on an intro, but we had coffee a couple of weeks ago because I was up in Seattle and she lives here, literally in the next building over from here, which is funny. But we got to talking, and it took me a while, but I actually got the nerve to ask her if I could see her artificial pancreas, and it felt so inappropriate, right? Can I see your artificial pancreas, please? It's I had no idea how she was going to respond, but whatever. What the hell? What the heck? What the hell? I did it anyway, and she told me, and I have to say, there's not a lot that blows me away. This actually blows me away. So I am so excited to introduce Dana Lewis.
Thanks, Bert. Thanks, everybody. I need to do something really quick. Hold on one second. Hey, Siri, text my artificial pancreas.
Here's what I found on the web for Watts again.
This is why you don't do live demos. Text my artificial...
Sorry, I missed...
Text my artificial pancreas #speaking.
Ready to send it? Done.
So I just texted my artificial pancreas to set a different target because I am speaking and my adrenaline makes my blood sugar go up. However, as cool as it is, maybe, to be able to text my artificial pancreas, that's not actually what this is all about. This is really about what's possible when average people, like you and I, decide to stop waiting. And that may be waiting for an answer for somebody to say yes to you. It may be waiting for the traditional scientific and medical communities to come up with the solution for us. And I have to tell you, people always ask me, well, you must be an engineer or a programmer, or you're something. You built an artificial pancreas, right? Well, the answer is no. I'm not any of these things. I'm not a rocket scientist. I'm not unique. What I actually am a girl standing in front of the world telling you I was tired of living with type 1 diabetes and the burdens that come with it. Because what a lot of people don't understand is that when you're diagnosed with a chronic illness, it's like getting struck by lightning. You can't prepare for it. You just have to deal with it. And in the case of diabetes, a lot of people have heard of it. You maybe have a family member with it, but it's actually really hard to understand the complexities and the challenges of living with it because it sounds easy. Well, if your pancreas doesn't produce insulin, you just take insulin, test your blood sugar. That's easy, right? Well, those things you can measure. You can measure your blood sugar. You can measure and account for how much insulin you're putting into your body. However, you can't account for stress. That adrenaline I was talking about that's making my blood sugar rise right now, how on earth do you measure that? What happens if I walked instead of just across the street? What happened if I walked a mile and then did this? How exactly do you precisely measure the difference between a half mile and a mile, whether that's a mile walking at a slow, leisurely pace or a fast run? These things are really, really hard to figure out. And there's not just things that make your blood sugar go up, there's also things that make your blood sugar go down. So it's constantly challenging between measuring these different things and basically just responding all the time, 24/7, 365 for as long as you're going to live with this disease, which right now is forever. And in my case, it's been almost 15 years since I was diagnosed with type 1 diabetes, and that is a long time. I've now lived over half my life with type 1 diabetes and dealing with the constant overflow of numbers and data and information about my body that I was previously unaware about. And a lot of people don't understand, but diabetes is actually the ultimate DIY. People with diabetes make over 300 decisions a day that impact their blood glucose levels. You guys have probably made dozens of decisions today alone, and they impact your blood glucose levels, but lucky for you, most of you have an amazing immune system and your pancreas is still kicking out insulin and other hormones. Mine is not. So everything from what time I got up, what I ate, 3 things I did before I ate, what I did after I ate, when I got here, there's so many things that go on. And so people with diabetes are constantly experimenting. It's a constant experimentation. I've done several experiments today already. What happens if I put in a certain amount of carbohydrates and then I only eat half of it now and half of it later? What if I eat all of it now? What happens if I do my insulin an hour before versus 15 minutes before? Oops, I forgot, 5 minutes later. There are these constant experimentations and people are constantly getting feedback about what's working and what's not. And the challenge is we're often getting feedback about what didn't work. And you really have to drill down and figure out, okay, this thing happened. Which of those 4 things that I did was the thing that didn't work? And really iterate and really, really go from there. So people often say, surely there's a technological solution for that, right? Well, technology would be great. And adding technology to diabetes is very helpful. It's like going from driving manual stick shift to automatic. For those of you who have driven stick shift, you know that driving automatic is very, very different. I've never driven a stick shift, but I know about it. And I know I would not want to do that. Well, living with diabetes is like driving stick shift. And when you start adding technology, it helps quite a bit. Now, think about the difference from driving automatic the way we grew up doing, and then adding in something like cruise control. Cruise control is helpful, right? If you say, hey, I want to stay at this target speed, the car is going to help you stay at that target speed unless something comes up and you need to intervene. That's the kind of technology that people start thinking about. Well, instead of having to deal with all these fluctuations in your blood sugar, wouldn't it be great if you just said, keep me at 100 and you stayed always at 100? And then there's a whole nother level of technology of the idea of self-driving cars. Wouldn't it be great if you could take your hands off the steering wheel and just kick back? It steers, it sets the speeds, it watches out for obstacles. If something comes up with this, it would deal. That would be amazing, right? Well, in diabetes, that ultimate technology, that self-driving car, is an artificial pancreas. However, I've had diabetes for 15 years. I was diagnosed in 2002, and upwards into 2013, 2014, this technology didn't exist. And I thought, you know, it would be great to have this, the holy grail self-driving car. Well, we didn't even have self-driving cars back then. But I would settle for, you know, cruise control or something else. But my challenge was that this stuff didn't exist, and the only technology I had was my insulin pump and my continuous glucose monitor. Now, don't get me wrong. I am incredibly privileged and fortunate because I can, A, afford my insulin. Insulin affordability is its own subject that I won't get into right now, but that's a huge deal in of itself. And then I'm able to afford the insulin pump, the continuous glucose monitor, and my sensors and supplies for that. So I'm very, very fortunate. However, a lot of people think that this is the holy grail, that these 2 devices that don't talk to each other are all a person with diabetes need. Well, in reality, the answer is no, because even with the latest and greatest technology, it's still really, really hard. Do you remember the graph with the squiggles that I showed you? That's not a bad day. That's every day for life with diabetes. And a couple years ago, my doctor asked me to bring in at my next 3-month appointment, just track things for a week. And I had a continuous glucose monitor and insulin pump, but they're made by different manufacturers. And the FDA-approved software for the glucose monitor, I had a Mac. It was approved for PC. Who here has a Mac at home? You guys could not have access to your data either. I had to borrow my then boyfriend's laptop to get my data off of my device. It's so frustrating. So my solution was, because I didn't think that was a good solution, I used the other device in my pocket that I'm so fond of, and I took a picture of every day, and I copied and pasted that picture into Excel, and printed it out and took that week's worth of data to my doctor. The frightening thing was, my doctor didn't even bat an eye, because he is so used to patients having to walk uphill in the snow both ways and to fight to get their data off their devices. So if it's this hard to get retrospective data off your device, can you imagine how hard it is to get real-time data off your device this year? There was no solution for this that existed. And my main problem was that I moved from Alabama to Seattle for work, and I lived by myself. And this device in my pocket, the glucose monitor, it has alarms on it. But it's that red and yellow line. You get alarmed if you cross that line. Well, if you cross that line, you're already high or you're already low, and you're possibly in a dangerous situation. So if you live by yourself, those alarms are what's supposed to wake you up and say, hey, dangerous situation, please do something. Well, I have this really special feature. It makes me a champion sleeper. I sleep really well, really long, and really hard. I never grew out of that. And so I would sleep through the alarms on my continuous glucose monitor, which terrified me and probably terrified my entire family, especially when I moved across the country by myself. Because if I failed to wake up to the alarm and I was in a serious low situation, how many hours would it take before somebody figured out that I didn't show up at work, thought to call my apartment building, send somebody to check on me? And so my solution for many, many years was a non-acceptable solution, but it worked. I had my mom text me every morning. She lived in Alabama, and she would text me, and I would text her when I woke up. And if she didn't hear from me, she would call me. And the idea was then if I did not respond to the text and the calls, then she would call the apartment manager, 911, et cetera. Luckily, that never happened. There was never a dangerous situation, but I lived in fear. And I actually had a dream one time where I woke up paralyzed in the dark, couldn't move, and my brain was thinking, okay, you have diabetes, there's something going on, your blood sugar must be low, do something. And I could see my glucose monitor alarming. I could see the juice box in my stand. I kept telling my body, reach for the juice, drink the juice, I can see your blood sugar dropping, do something. And I couldn't move. And I woke up the next day in tears and terrified, and I didn't want to go to sleep the next night or the night after that. It was terrible. So I thought, there's got to be something we can do. My phone makes really loud sounds and really loud alarms. Surely there has to be a way to get the data off that device and make louder alarms if the manufacturer won't do it. Because I'd spent years asking the manufacturer, hey, can you make louder alarms? And the answer was, they're loud enough for most people. Doesn't need to be louder. Trade-off, battery life, whatever. That was not good enough for me. Now remember everything I said about how hard it was to get retrospective data off. I wanted real-time data. That was close to impossible. So for the longest time, I just did my workaround with texting my mom and dealing with it. Now, if we can't change the existing FDA-approved, marketed, distributed medical devices, and we want to add technology, what are the things that we could do? Well, for me, I am on Twitter pretty frequently, and I actually ran across a picture of somebody who figured out how to do this. He posted a picture showing getting his son's glucose monitor data to a computer, to the cloud, and he was at work, his son was at daycare, and he was able to see his son's blood sugars. So I reached out to him and said, hey, this sounds really cool. Would you be willing to share your code with me? And he said yes. And that was amazing because I was able to use that code and upload my blood sugars using that borrowed computer to the cloud and send them to my phone. And I wanted to share them with my family and my loved ones because instead of just texting me, wouldn't it be great if they could just see she's probably sleeping, but her blood sugar's 100 and just fine. But I didn't want them to get alarmed all the time. So we added these snooze buttons to the page. So if I did appropriately wake up to my alarms that are now loud and appropriate, I would hit snooze and say, don't wake anybody else up. But if for some reason I didn't press the button, it would escalate and wake them up. And in fact, in the first 2 weeks that we had this basic web page with the buttons, I went really low. I was sleeping through it, and my then boyfriend, who lived 20 miles away, got the alarm. He woke up, he called me, and that was enough to wake me up. I drank juice, I was fine. So the system worked really, really well. Well, because I was pressing buttons, I thought, they probably want to know that I'm doing the right thing. So if I'm low, I'm not taking insulin. If I'm high, I'm not drinking juice. That's the opposite of what you should be doing. So I started actually pressing preset buttons that said, I'm doing insulin, I'm eating food, here's what I'm doing. And because I became this incredibly well-trained guinea pig, entering all of my data, we are like, hey, we should do something with this data now that we've got it all in one place. And so we built a predictive algorithm that looked into the future and said, not just here's where you are right now crossing that threshold, but here's what you're going to be in the future. And if you want to change the future prediction, take action now, and you will prevent the high or the low or make that high or low less severe later on. And this was absolutely life-changing. So this system was very, very basic. It was not a shiny, revolutionary app. It was a basic web page and a watch view, so I could look down on my watch, or anybody in my family who I gave my data could look down at the watch and see my information. And it had those just basic buttons that I could press. And what's cool about it is this is a DIY system, right? This was something we totally built. It's not FDA approved. It didn't come from device manufacturers, so we could build what we wanted. And we iterated over time. What we built the very first day, we had changed by day 2 and day 3. And we were able to say, ooh, this worked well. This didn't work well. Let's rearrange the buttons. Let's make this bigger. And it was really interesting because I had never designed or developed or done anything. So it was interesting to just test and tweak and try again, and test and tweak and try again. I knew how to do that. Diabetes taught me that, but now I was doing it with technology. The other cool thing was teaching my then boyfriend about diabetes. On our first date, I pulled out my insulin pump intentionally to bolus for my dinner and to start a conversation about diabetes and to kind of see how he would react. he thought it was a pager. So we had a little bit of an uphill learning curve in teaching him about diabetes, but not just teaching about diabetes, but how could he help? And he became my co-developer and partner in this whole experience. But what was really interesting is one time I was traveling by myself, and he texted me and said, "Ooh, I see you're low, I'm sorry. Is there anything I can do?" And it was quite a significant low. I was fine, but it was one of those things that left you shaky and frustrated and feeling like you kind of had to pause for 5 minutes. Not that big of a deal in the grand scheme of things, but over the course of 15 years, I've had a lot of those 5-minute pauses that adds up. It's just not fun and not fair, and you want to be present all the time in your life. And so he said, "What could you do to help?" I'm like, I wish you were here and you could give me a hug. He's like, "I'm sorry, hugs via text, very sweet." Well, a couple weeks later, I was walking between 2 of my campuses for work, and the combination of eating and then walking caused my insulin to go what we call whoosh. It worked a lot faster than expected. So my blood sugar started dropping, and my system said, "Whoa, you're dropping. You need to do something, and not just reduce your insulin, but you actually need to eat a lot of carbs." And so I pulled up the system to press the button that says, "Hey, I'm drinking a juice box," and I noticed this, 34 carbs and 1 hug required? What? So I click on the hug, and this is what pops up, is this image that says, "Sending you a bear hug." And I felt so much better, which was his intention. He didn't tell me that he was coding this into the system. But it was so sweet, and it makes me smile every time I put it up in the presentation, because it's those little things that no FDA-approved medical device is going to give you a hug. My devices give me a hug. And that's just one of the things I love about DIY and about the little things that when you're partnering with somebody who deeply understands and learns from everything that they're learning, it's phenomenal. So this is kind of like cruise control, because it would tell me, hey, you need to do X and Y and Z to stay the same speed and stay in the same lane. But again, what else could we do if we added technology to the existing medical devices? And because I am fond of social media, as I had been developing the system that we jokingly called DIYPS for the do-it-yourself pancreas system, even though it was kind of like an open loop system, we met a lot of other people in the open source world. Because this was my first introduction to open source code, was this guy who said, "Yeah, I'll share my code with you." And we met another gentleman by the name of Ben West, who spent years figuring out how to talk to another medical device, my insulin pump. And he figured out how to communicate commands to the insulin pump. And I thought, ooh, well, what I have is actually an open loop system where all the data is read, it's processed through the computer, but then I, the human, am still closing the loop by pressing buttons on my insulin pump or eating something. How cool would it be if we could close the loop? Could technology help with that? And the answer was yes, because we actually had everything we already needed to create a hybrid closed loop artificial pancreas. If you take your existing insulin pump and continuous glucose monitor, and you add a small computer, a battery, and a radio stick, you get an artificial pancreas. And I have to tell you, life with a self-driving car, an artificial pancreas, is amazingly different. So the pictures I showed you before with the up and down and the up and down and the up and down, I still get those occasionally, but there's less up, less down. There's not 20 of them in a day. And I get a lot more graphs like that, especially overnight. All of those flat lines represent 8, 10, 12, 14 hours where I slept the entire night without waking up because of diabetes. That doesn't sound like a big idea, maybe a big deal to you, but for those of you who've had children, do you remember the feeling when your child went from sleeping 3 hours a night to 4, 6, 8, and then all of a sudden they were grown up? That's what it feels like going from non-artificial pancreas to an artificial pancreas. It is that difference in sleep quality, and not just sleep quality of the time of sleep, but feeling safe to go to sleep at night. I can't tell you what it feels like to be in a hotel room by yourself and being afraid to go to sleep because you don't know if you're going to wake up at night. That has not happened to me now in almost 3 years, and that is revolutionary to me. And if you can imagine somebody, a kid with their baby doll or their teddy bear, and they just don't want to let it go, that's me on the right side with my artificial pancreas. We had originally designed this just for overnight usage because that was the problem, right? I was afraid to go to sleep. Well, what happens if you don't want to let it go? Well, you plug in a battery and you take it with you. And so this was, I think, the first night. After the first night I'd slept with it, we went out for dinner, and it's cold in Seattle, it's in December, and we're walking through the streets, and I'm holding it like, this thing is really working, this is so amazing. And it worked until I broke it 3 days later. And the next 2 days were terrible because I had to wait for replacement parts. But we're not talking about approved medical devices, we're talking about Raspberry Pis. and SD cards that you buy on Amazon, overnight shipping. This was before Prime Now. Now you would get it in an hour, but then I had to wait 2 days for my replacement parts. But this really, really, really changed my life. And I thought, you know, like so many other people, and what you'll hear about today, I couldn't keep this to myself. I couldn't do it. This was life-changing for me. If somebody else wanted to do this, I wanted to help them. And so we decided to open source the code, the documentation, and everything that we had to help people do this themselves if they so chose. And so that's why we created OpenAPS, which stands for the Open Source Artificial Pancreas System. It's not a company, it's not an organization, it's just a hashtag and a movement, but a really powerful one that says we're gonna do everything we can, openly and transparently, to try to help make this basic technology. It's very, very basic. But even a basic artificial pancreas is so much better than the standard of care that most people with diabetes are living with. And we're going to do everything we can with this technology to help reduce the burden of type 1 diabetes. And people often say, okay, well, that's just you. Surely no one else is crazy enough to do this. Nobody has the technical expertise to do that. Well, the answer is wrong. Because the community came together, not just around the code, but also in improving the documentation over time, there are now over 310 people worldwide of all ages using a self-built artificial pancreas. Again, everybody has to buy the physical hardware parts. They have to put this together themselves. They need to review the code. They need to decide it's right for them. There's a bunch of different settings and things that you can do. But these people did it. They were determined because they knew that diabetes was providing them challenges and preventing them from living the best life that they could. And they wanted to try it. And so they did. And it's really powerful because we as a community have over 1 million hours of patient data living with this technology. Now remember, I said in 2014, this type of technology was not commercially available. There is one commercial device that just got approved and is starting to come out to market, but it is not widely available. There's a huge line of people waiting for it. It's not by any means perfect technology. It's a lot better than standard of care, but it's not here yet. And then affordability of devices. There's a lot of complications and things that go into that. So it's really, really important that we continue to iterate and innovate with this technology because it is so much more affordable and accessible and an option. Not right for everyone. DIY is not right for everyone, but for those who want to try, who don't want to wait, this is an option. And it's great because humans are lazy. We round up, we round down, we get tired. We don't want to do something every 5 minutes. This device on my hip, for those of you who can't see it, this is my artificial pancreas. It doesn't get tired, it doesn't get lazy, it doesn't go to sleep, as long as I keep the battery plugged in. And it works every 5 minutes, all night long. So I can sleep and it doesn't, it's great. It's not a cure, but it is incredibly powerful and it makes my life so much better than it used to be. So I wonder what if. Yes, this is just diabetes, which is, you know, a very data-driven disease. We have access to technology, we know a lot about diabetes, but what if we all started using technology to make small changes? We can't cure everything with technology, but what about these small quality of life improvements? Like what if we made alarms louder? What if we hooked device A and device B together? What if we provided patients their data in real time? What could possibly happen if we start doing this across all disease communities and all patient communities and got these incredibly large quality of life improvements? How valuable would that be? And what if we stopped expecting traditional stakeholders, only the medical device companies, only research scientists, you know, only the medical industry? What if we stopped waiting on them to innovate and come up with solutions for us? And what if we all say we are not waiting? That is another hashtag and a movement that we have really brought up out of the diabetes community, but we are not waiting is a global hashtag that says we are not going to wait. And so I want to challenge you guys to make that commitment, make a specific commitment today, but think about doing it in the we are not waiting style. Say we are not waiting to change X. It doesn't have to be big, but start with something. Something is better than anything, and I bet once you change one thing, once you say instead of 6 months, let's do it in 1 month. If you get a very first rough version of something accomplished in 1 month instead of 6, you can continue to iterate, and I guarantee that by 6 months, you will have something radically better and different in 6 months, and you will have helped people for 5 additional months. How powerful is that? So for me, we said we're not waiting to change how I sleep at night. And we said, we're not going to wait to make this available for other people and possibly help change diabetes care. And now we're saying we're not waiting to tell this story and hope that inspires other people in healthcare, whether you work professionally in healthcare or you're a patient or a doer, to help change the rest of healthcare because we all know it needs changing. So with that, I'll stop here, but I just want to say, I want to know, what are you waiting for? Thank you. So obviously question time.
This is very exciting integration of technologies. It seems like you're putting a great deal of trust in the actual blood glucose detector. And in my experience, those have been fairly unreliable. So how do you close the loop when there's that element that is, so iffy?
That's a great question for those listening online. She's asking about the reliability of blood glucose monitors. And in particular, we're talking about a continuous glucose monitor that reads every 5 minutes, and it relies on the human to calibrate several times a day. And obviously, if you don't trust the sensor, you probably don't want to do this. However, I've worn continuous glucose monitors for, 12 of the 15 years I've lived with diabetes, and the ones I first started with, I wouldn't have been able to do that with. But the technology we have today is actually, some of them are FDA approved to dose insulin off of. Some of them are not FDA approved to dose insulin off of, but we individuals, we do what we want to do. And several of us have been self-dosing insulin off of it for years, and I actually automate that. And I do trust it to dose insulin because the accuracy has improved significantly. I calibrate it and I validate it. But I also, in terms of closing the loop, one important thing about how we designed OpenAPS was to design for failure. What happens if you miss a data point? What happens if you have a data point that jumps way up, way down? That could be a real rise or drop, or it could be the fact that you rolled over and blood flow is impeding the reading. And so we designed to identify those situations and also not rely on a single data point. The other thing, just in terms of how OpenAPS works, is it doesn't ever give you large doses of insulin. It sends these commands of what we call temporary basal rates. So basically, a temporary command for 30 minutes that overwrites the basic settings on this pump. So the idea being, if somebody took this and ran away with it, I stomped on it, the battery came undone for whatever reason, at the end of 30 minutes, that command, which we calculated to be the safest thing to do based on all the available data, we say, okay, well then it just goes back to the pump settings. So if it reads in 5 minutes and it sets another command, great, but if for some reason something happens and it fails, it goes back to your normal pump settings. So you fail back to the standard of care. But obviously one thing in the diabetes space specifically that I've been advocating for is talking about the limitations of these types of systems, whether it's commercial or DIY, and the care and feeding of the underlying devices is absolutely critical, because you have to have a working insulin pump that's getting insulin into your body. You have to have a good pump site, and you have to have a continuous glucose monitor with valid readings. It's a great question.
Can I just add, it looked like you were using the Dexcom, but now that Medtronic has an integrated one, how do you feel about the new Medtronic integrated one, where the devices are made by the same company?
So she is asking about how do I feel about the first commercial device and pointing out that it's made by the same company. I think it's interesting because our system actually, I happen to use the Dexcom sensor right now with an old Medtronic insulin pump. You can do OpenAPS with whatever sensor you want. I actually think having a full-in-one stack with the pump and the algorithm and the sensor being made by the same company is challenging to people with diabetes because you have less to choose from. You have to choose basically this black box or the white box or the purple box when there's multiple commercial systems available. And I've actually been advocating to the companies to provide more insight into how the actual algorithms work, because it's not about the box on your hip. You can put a sticker on it. But how does it work, and can you trust the sensor readings, and what happens if it fails, and all these things? That's something I'm really interested in exploring, and also the FDA has expressed interest in this idea of interoperability, of separately approving pump, sensor, and algorithm as a standalone, so that we can continue to iterate in all three areas and not just have micro improvements in one area, but it's being sold in the stack, so it's marketed differently. So I'm excited to see the changes about that over time. Yeah.
So Angela from online wants to know, what were your liability concerns when you decided to make this available to the public?
Great question about liability and risk. So we decided not to create a company, to not patent this, to not do whatever, but to MIT license our code and the documentation and make it open source. And we can't remove all liability from it. Certainly somebody could sue us for any reason, but we wanted to put it out there and say, you can read every single line of code. and it's written almost in plain language. So even if you don't have any coding expertise, you can look at it and see exactly what it's doing and decide, do I want to use this? Do I want to change it? What do I want to do? And decide if it's right for you. And that's a very important part of this project. And that's why we emphasize the n=1 times 310 or whatever the number is, because this is totally everybody's individually self-experimenting and self-building these devices. So you decide, I want to buy this thing, I want to make it talk to this thing, I'm going to load this open source software on it. There's a lot of different moving parts and pieces, and overall, you make dozens of decisions as part of the build process, let alone the ongoing decision to use it every day, that I want to use this and this is right for me. So we very intentionally wanted to design it so if somebody without any clue managed to build this all, that'd be really hard if they didn't have a clue. But if they managed to build this all without a clue, it's built with default settings so that it cannot give you any excess insulin above what you would normally get until you know the system well enough to go and change those safety settings. So we very much designed with that in mind, but also wanting to give people the ability to, if they wanted to use it and they don't have coding experience, they should be able to build the system themselves. So that's the approach we took, knowing that, again, somebody could sue for any reason, but we believe that we've built this, and because it's so transparent, and we've got the peer review process around the code and the documentation, and multiple people look at anything before it gets shared and published and encouraged and tested, and it goes from a development branch to the master branch. That whole process that comes from open source and a lot of other workflow actually helps us all make sure that we're always thinking about all the edge cases, all the safety scenarios that we need to be thinking about.
How do you deal with security and protecting your information? Are you storing your data in the cloud, or where are you storing it?
Great question. So the data always lives on my existing devices, which was true from before, and it was really hard to get to. I'm also choosing to use something called Night Scout, which is another open source project where I put my information in a web viewer that my family can see, that it's protected that way. Somebody could hack it if they learn that I have diabetes. Not that big of a deal, but I think it's a great question, especially as we start thinking about the medical devices now that we design for the future, designing in a way that we don't know what the technology is going to be or what we're going to need to do, but we need to think flexibly to both allow patients access to our data and real time and retrospectively, but also think about the security aspects of it. It's a great question.
So I was going to ask, and you kind of alluded to it a little bit, but what kind of pushback did you get from the manufacturers? What kind of liability are you exposed to there as well? I mean, they're going to come after you and try to claim that you're busting their patents, and they don't always behave kindly to patients or people doing stuff like
I think
this,
that's unfair to the manufacturers in the diabetes space because they've actually been wonderful. They cannot officially support or bless or endorse us, but they know that we are actually pushing everybody. We are educating the diabetes community about what this technology can and can't do, and what are the risks and what are the limitations. We are showing the FDA about the thirst and the fact that people are willing to self-build these things. We desperately need this technology. It's better than nothing, right? And so it's actually, we've been told, has expedited several device reviews and approval with the FDA. So it's helping the FDA, it's helping the companies, so they like that. And they're also learning from it. So the other reason that we very specifically open sourced our code, our documentation, I'm blogging, I'm talking about it. I was at the world's biggest diabetes scientific conference this weekend presenting a poster to healthcare providers and researchers in these companies to say, look, you'd be stupid not to learn from this. Over 1 million patient hours. How can you not use this as part of your process? Now, not all of them are. Some of them have a ways to come, but we have not got any cease and desist letters from manufacturers of the FDA. We've not had any really wrenches thrown in our process. And I think that's a testament to the safety design, but also the transparent, open approach we've taken to communicating about it.
different than the pacemaker manufacturers, and
Yeah, there's a lot outside of diabetes that I don't know well enough to speak to, but I have been pleasantly surprised with how supportive behind the scenes some of the individuals from companies have been, where they're not representing their companies, but they're saying keep on keeping on.
But I think
because it's helping
diabetes
everybody.
is a certain disease family that ethic exists there, and it doesn't necessarily exist with other manufacturers that you might not know about. But I mean,
Yeah, I
that's
can't
why I'm
comment
asking
on
the
that, yeah.
question.
Yeah.
He actually asked one question.
Okay, great.
So I don't know a lot about diabetes, but I'm wondering, my husband has type 2 diabetes, and I'm wondering if something like this could help him in the sense of knowing when to eat, what to eat. Do you understand what
Yeah.
my big question is? And
Yep.
I don't know too much about diabetes to know the difference of type 1 and type 2 in and out, but I'm just wondering, could this help somebody with type 2 diabetes in a different way? Because obviously he's not injecting
Yeah.
with insulin, but to know when, just to get him on track because he's just really struggling.
Yeah, the question is about could this help for type 2 diabetes? Probably the easy answer is if they're not taking insulin, that this system itself is not for them. However, continuous glucose monitor technology is something that people with type 1 have been using. It gives you a data point every 5 minutes. Well, actually, people without diabetes have been wearing them, and people with type 2 diabetes have been wearing them. And my husband wore one, and it was very fascinating. He does not have diabetes, he doesn't have prediabetes, but when he eats something or if he drinks a sugary soda, it is really telling what the difference is in the blood sugar spikes. So I think that type of technology alone will be really helpful to a lot of people, but also people with type 2. Maybe they don't need to wear it all the time, but if you wore it for a week, it'd be really fascinating. And there's actually different types of technology coming out. There's one called flash glucose monitoring, where you basically wear a little sensor, and it's not real time, it's not pushing to a device, but you have a little handhold scanner and you track over it, and you can get the same real-time readings over the day, and you can see, okay, I ate this, I did this, here's what happened. So I think the advances in glucose monitoring alone will be very, very helpful also to type 2, but also other people where we want to see how, what happens when I eat wheat with my meal versus not. We're going to see some differences in blood sugar patterns from that. So I think having cheaper and more affordable and accessible different kinds of devices is only going to help everybody.
Well, and also, so I have hypoglycemia, and I think part of the reason I have hypoglycemia is because I don't know what to eat, when to eat it, and I probably don't eat enough. And so my body's just always doing this spike, and it sounds like that could help people across the board and really improve lives,
and that's exactly the self-experimentation that people with diabetes do. It's like I ate a bag of chips in the airport because that was the only gluten-free thing I could find. Whew, that's different than when I have protein and fiber and vegetables, but it was better than starving to death in the airport. So constantly being observant to those kind of trends and the signals from your body, that's something that diabetes teaches you, is to pay attention. And I think that's something that other people would definitely benefit from. So it looks like we have some online questions as well.
Abriwi 3010 from Idaho wants to know if you've had any other disease communities inquire about your creation.
Great question. So the question's about any other disease communities like inquiring about the creation. The answer is yes. And I'm often asked by people like, how can we do this? And that is one of the things that I want to inspire. It is this type of mentality and DIY and innovation. We are lucky in diabetes that we have medical devices that give us data. But this idea of looking at data in real time, using it in new and different ways, and DIYing is not at all unique to diabetes. And in fact, that is kind of one of my passions for this year, is to figure out how can I work with people in other communities who know what their problem is. They know what the quality of life problem is. But what could we do with technology or data or basic computing technology and make it possible to do something different? So I don't have a great plethora of examples right now, but I'm hoping in the next year, 2 years, that I'll be able to rattle off a huge list, and I'll even forget because there are so many great examples of all the patient communities doing this kind of DIY innovation stuff.
I have a really silly question, which is, how does a glucose monitor work?
The continuous glucose monitor?
Yeah.
Yeah, so I have a sensor on my arm that is taped down, and there's a little sensor under my skin, and it reads through the transmitter, which beams to the device in my pocket. And I'm able to, in the old world, press the button and look at the number. But this is also paired with my phone. So it sends the data also to my Pancreas or to my watch or to my phone, so I'm able to look down and see it. So basically what it does is it's the sensor and the electrodes and everything, they send data every 5 minutes based on what the blood sugar reading is. And if you want a more technical answer, I encourage you to Google it.
No. I was like, the people, how long ago did people stop just poking themselves and doing that?
So finger stick is still very, very common. I, in fact, do that twice a day to calibrate this device. So we were talking about the accuracy. You have to still validate this and basically train it with the finger sticks. But when I was diagnosed in 2002, I was testing my fingers 14 to 15 times per day. And that sounds like a lot, but this thing gives me 200 plus readings a day. So, it's like getting 12 Polaroids a day and saying, here's how your day went, versus like a full moving picture. And so finger stick's still there, but again, it's like the Polaroid. If you only test 3 times a day, you get a single point in time. It doesn't tell you here's what's happened up till now or here's what it's going to do next. And the power of visualizing your data, even if it is just the finger sticks, is really powerful because when you see it in your eyes, it's very easy to start to pick out trends and spot and say, ooh, maybe this is related to this. So interoperability of medical devices, getting data off of even things like regular glucose monitors or continuous glucose monitors or heart rate monitors or whatever it is really, really valuable to help patients start to correlate between thing A and thing B.
Thanks.
Yeah. So there's 2 questions behind you, I think.
Thank you so much for sharing your journey. You had me thinking about commercializing and bringing devices to market. And so I see kind of 2 ends of the spectrum where you and the DIY community are moving incredibly fast and making incredible strides. But there are a lot of patients who may not be comfortable with that kind of risk. And then there's the FDA who moves incredibly slow, because they're trying to guarantee almost a no risk sort of product.
Yep.
Where do you feel the right middle ground is, or what kind of process do you see working to kind of optimize both for safety and for meeting the needs of patients?
So it's the question is about the spectrum between DIY, people who aren't going to wait, and the commercial devices that have to be FDA approved. They have to work for everyone. They have to be fail safe. And we just had that before, that FDA side of the spectrum. What I'm saying is it's no longer in black and white, this or this, but it's a gray area. In some cases like diabetes, what we're doing is going to be brought to the market by the traditional companies, and that's great. However, they've been working on it for 5 years, 10 years, and we're able to make them move faster to submit it to the FDA. It's not the FDA that's slow in many cases. It's actually the companies who are waiting too long to talk to the FDA to bring their products to market. And at least in diabetes, CDRH at the FDA said, come talk to us early and often and let us help guide you so that when you actually submit, it's a fast review and a fast approval because we don't have to uncover like 3-year-old mistakes or problems that we would have raised 3 years ago. So I think that's helped. But it's also, there's no reason for a small patient community to continue to iterate. The algorithm that we have today is different than what we had 3 years ago. The commercial product that's coming out today is very similar to our first generation 2014 algorithm, and what we have might be in their next generation. And I think we are continuing to raise the bar and say, here's what's possible for technology to do. Here's the trade-offs you can get between outcomes and quality of life. Or in our case, we're saying you don't have to trade off between great outcomes and quality of life, whereas the first generation of commercial devices are like, let's just get this through by any means possible and get into the market. And that's important because there are people who cannot DIY or don't want to DIY, don't feel safe for it, and they need the commercial solution. There is I'm not saying don't have a commercial market. We do need that, and that's going to be great for a lot of people. But I think it's an incredibly interesting ecosystem now with the DIY communities growing up and continuing to partner with the companies, with the FDA, and with the patient community because we also are very responsive. Somebody says, ooh, I wanted to do X, or what about in this situation? Now, it's not just, you think about people complaining about medical devices and you're like, oh, I want a louder alarm. That seems silly probably to people at the companies, but that alarm is what I thought was going to keep me alive. And that's my number one problem, and that's what I want to solve. And we have other people who are like, oh, this is great. However, my kid is now in a different school and with a school nurse, and we're in this different situation, and we need design for this. And we're able to respond. And within hours or days or weeks, depending on the complexity of the feature, ideate, create it, test it, and then roll it out, and people continue to test and improve. So it's really about that constant iteration and improvement, and not just saying, okay, yeah, we'll get there in 5 years. That's never okay. And that's kind of where the we are not waiting comes in that says, okay, you might bring something out in 2 years that does what I do, but I want to sleep for the next 2 years, so I'm going to do so. Yeah. Question back here.
You touched on a couple of things that I find interesting, which is, the whole concept of quantifiable self on an ongoing basis. I think about the future of healthcare where measurement needs to happen on an ongoing basis in our lifestyle, not just when we go see the doctor.
Yeah.
So I'm curious in terms of what trends you're seeing there and what other signals can be collected on an ongoing basis in a way that makes sense to ultimately better inform our healthcare or sick care by the time we get it from the doctor. So some of the things that I've been looking at are things we could measure in the bathroom potentially on an ongoing basis. And so are there other do-it-yourself initiatives around that? And what are some of the things that you're seeing in the industry around other things that we can measure on an ongoing basis?
Yes, the question is about the trends in quantified self and people self-measuring and tracking, and what data could that bring to healthcare, and what examples. The most practical examples that I see is people always ask, ooh, what about activity trackers or heart rate monitors? Those are things that we know how to track. We've got them in devices. How could we incorporate that into the system? I think the more interesting nuance of your question is, well, what does healthcare think about all this data, and is it equipped to deal with all of the self-tracked data? And the answer is no. When I walk in with an artificial pancreas, my healthcare provider is like, ooh, I want a week of CGM data, or I want a single data point. And they're kind of missing this, but that's because to their credit, there's no tools being developed to deal with the masses of data. And I think as we have more devices, as we do more self-tracking, we also need to be thinking about healthcare providers and the tools for patients to package their data and present it to providers in a meaningful way, or for providers to look at all the data and pick out patterns and trends and everything. Just like they're not taught about true nutrition, they're also not taught about big data and all these new devices, and they're learning alongside us. So we need to bring them into the conversation too, and make sure that when we talk about healthcare and we talk about all this innovation, we're making sure that the healthcare providers are equipped and able to help us patients if and when we want to seek guidance. They're not always going to be able to give guidance to me in my artificial pancreas. I'm not expecting that. But there is some level of data that I need to be able to present to my doctor and say, okay, if my 1 3-month average number is this, here's why, here's everything that went into it, and enable him to scale down as much as he wants to, dig into that data as much as he wants to, or just stay at the high level and still yield insights from it. Yeah. Okay.
Dana, one more question if I could?
Yeah.
Thank you so much.
I hate to do this, but for the online audience, we actually do have to break, but Dana's going to be here a bit. So
Yep.
2 things. One, she'll definitely answer your question, I hope.
Yeah.
2, you definitely want to ask her about her shirt, because we didn't get time to ask her about it. And then 3, there are some online questions if you could come over and answer
Sure.
those too. But we'll start the next session at 10:40. So thank you, Dana.
Yeah.